All right, last but not least, working on posterior glide of the glenohumeral joint at 90 degrees of abduction while working into internal rotation. It is the last bit of motion that a lot of our clients are able to get depending on what diagnoses they kind of have going on. Sometimes after shoulder surgery, that's the last motion they're going to get. If someone has adhesive capsulitis, frozen shoulder, that's the last motion that they get. So just kind of keep that in mind. There's a reason that it's last in the progression. It's the last thing that comes back. But this is like a motion that needs to be cleared on a lot of our people that is literally what they need functionally. So it's also the most complicated setup. So bring this through. So we have a belt. We're going to bring it through close to her joint line. Okay. Now we also need a foam roll here to keep her humerus in relatively a neutral position, right? In abduction, neutral abduction, right? We don't want it to be way up high. We also don't want it to be, if I had just my leg here, it would be kind of stuck in a relative extended position. Okay, so we have it in a relative neutral abducted position. And now I'm going to bring my foot on the bottom portion of this belt so that I can maintain the humeral head posteriorly. Okay, so that maintains the humeral head posteriorly. We've already gotten her to a place where we have the inferior glide into abduction. Now we just need to maintain it posterior as she then rotates in. And so as I'm bringing her in, I can feel through her arm when that tension wants to come boop, up into the belt. Okay, so it's right about here, right? So now, Kelsey, don't let me pull you down. Good, slowly let that go. And I'm maintaining the block with the belt as I am taking her into further internal rotation, and hold there. And we just got some good range just on the first one. Normally have them hold about 5 seconds at least, and then slowly let that go. Yeah, and we're getting actually a good amount of motion. Are you okay from a numbness standpoint?
I'm numb.
She's numb. So because she's numb, we want to see when that how long it takes for that to kind of ease and go away. And this is like a good moment, educational moment. So ideally, I would have educated her ahead of time. Hey, let me know if you get some numbness down the arm. In this case, I forgot. And so I asked her part way through and she was numb. And so now I want to see, is it still numb? Okay, so she's not still numb. So like the irritability, that tells me the irritability of that numbness is not that bad. There are some people that you do that and they get numb and they stay numb for a minute, 2 minutes plus. And on those people, you're thinking, okay, was I too aggressive? That's one option. Are there soft tissue considerations that need to be worked on that I didn't fully clear? Because if you think about the progression, there's a lot of things that we should have done and cleared before we are on this step, okay? Another thing is, did I effectively work the other glenohumeral accessory motions to where the humeral head is actually sitting in a good position in the socket in order to actually do this mobilization, okay? So it's like backtracking of, okay, if she's numb, that is okay if it goes away within 15, 20 seconds afterwards. I may actually work through that. If it lingers longer, I'm thinking, okay, what else can I do to ultimately be able to do this technique? Okay, I'm going to flip it around again. If she does get numb and I still want to think, is there anything else I can do to maybe make her not get numb in this technique? So the same thing applies of, did I effectively do all the glenohumeral accessory motions? Did I effectively do the soft tissue considerations in the area? Is there something from her neck that may be contributing to that numbness? Just kind of trying to think of options and think out loud with the client, because then that builds even more trust, okay? So this is the setup. We want the arm to be in a neutral abducted position. We want to loop the belt as close to the joint line as we can. We use our foot through the other end of the belt to maintain that posterior glide. And then the goal is ultimately to work her as far into functional internal rotation as we can. And then let's say we get her to this range and it's not improving anymore. Then I could bring a hand to the posterior aspect of the humeral head and say, don't let me lift you up here. It's going to be hard for a lot of people. And then I could come on the inferior, on the wrist flexor side of the wrist, and then don't let me lift you up there. And I'm kind of tractioning up through my thumb as I try to not allow her humeral head to come up towards the ceiling. So it's posterior glide of the humeral head. And then we can maintain that for a while and then work on combination of isotonics into and out of that range to try and claim that new motion that we just got that they probably haven't been into in a long time. So we want to kind of wake their brain up to the option of being able to use their muscles in that range. Okay, so that is internal rotation at 90 degrees of abduction, maintaining that posterior glide of the humeral head.